Good afternoon. My name is Dr. Robert Pelley. I'm going to be the instructor for the Health Econ class. And before we get into the text that we're going to use, actually written by Dewar, but before we get to the text, I thought I'd spend a few minutes discussing what academics may consider the seminal article that drives healthcare, medical care, but the economics and then the research and the discussion of not only how economics affects either health, medical care, or healthcare, but also they will argue it was a seminal article that started the ball rolling just in healthcare in general. And that article we're going to discuss is Uncertainty in the Welfare Economics of Medical Care. Now, that article was written by Kenneth Arrow, published, I think it was American Economic Review in 1963. So basically what he's doing is he's discussing the healthcare market and research he's done at it. And even though it was published in 63, he could very well have been doing the research in the late 50s because there is some lag time, and it does take some time to get journal articles published. So not really sure when he started his research and started generating like the initial journal article. But when I was in graduate school at Ohio State, it was required reading. It was required reading in econ classes because there were a lot of individuals either getting PhDs in public health or healthcare administration, but we were all lumped together in econ classes. So it was required reading. And I think the academics will argue it was a seminal article that kind of jump-started a lot of what we see now in healthcare today, is because he talks about things like transfer payments, social welfare, public economics. And so what they will argue is, so Arrow publishes his article in 1963, comes out, people read it, and then lo and behold, you start seeing things start to happen in the healthcare environment. So if you think back, any of you that understand the history of healthcare, it's the VA was, I guess, the Veterans Administration, the government entity, was established in 1930. So that was kind of your first healthcare entity that focused on a well-deserving population, even though the federal government had been taking care of healthcare issues of the military since the Revolutionary War. It just hadn't been hardly as focused, or it hadn't been set up as an administration. So in 1930, they set up the administration for the VA. So it became a federal administrative body. And then lo and behold, after Arrow publishes his article in 1963, Medicare is, and I think Johnson was president, so Medicare is enacted and brought in under Title 19 in 1965, along with Medicaid. So 63, Arrow's article, 63, Arrow's article, 65, Medicare, 65, Medicaid, and CHAMPUS, which covers the active duty population and their family, is enacted in 1967. So started out CHAMPUS 67. I think the name was changed to TRICARE in about 1995, but still the same entity. So you've got Arrow generating this journal article, gets it published, and now all of a sudden you start seeing some activity in the healthcare space. And so I think that's why academics will argue that this could be the seminal article that jump-started what we know as healthcare today. And so as we kind of get into his article, he starts talking about normative versus positive statements, and normative and positive. So when you talk about normative statements in economics, you're typically talking about how the world should be, or what it should be. It's more opinion than it is fact. Whereas a positive statement, it's more along the lines of how it is, how it truly is. So it's more of a fact-based type of statement. And so he's talking about normative and positive statement, normative versus positive versus, and he lumps welfare, social, public economics all into kind of a lump. So, and again, I think that ties back to you had the transfer of payments that actually started it's jump-started Medicare, Medicaid, CHAMPA/TRICARE. And he talks about medical care is explained by uncertainty in the incidence of disease and the efficacy of treatments. So according to Arrow, it was an issue then. I'm not sure that many people, either whether you're a traditional student or a non-traditional student that's taken this health econ class, I doubt that very many of you are actually accessing or taking advantage of the healthcare environment prior to 1963. So he's kind of given us a history and kind of telling us, well, here's what it's like in the late 50s, early 60s, and here's what I think it should happen and what we should move in that direction. And he was right. So incidence of disease and the efficacy of treatments, it was uncertain and risky in the 50s and 60s. And from my perspective, it's still uncertain and risky. And here we are in 2023. And he talks about health. There's many causal factors. And medical care, at least in the 50s and 60s, as far as those individuals seeking medical care, it was, kind of a component of income. If you look at what's its component of your income today, most individuals today are covered by some type of health plan with a healthcare organization, with a health plan, Blue Cross Blue Shield, United, Aetna, Cigna, Anthem, regional plans, a lot of health plans out there that provide coverage, whereas back in the 50s and 60s, there might not have been that much coverage. So a lot of it was looked at as a portion of your disposable income. And the complex issues he talks about among physicians, hospitals, and public health. And I don't want to say it was a dysfunctional system, but it lacked a lot to be desired, at least in Arrow's mind, as far as, is it efficient, and is it, can you improve the quality of care that is provided in the system? So I think he had some concerns about that. And then he goes in and he talks about the competitive model. And, he starts down this line of the competitive model. And if you remember from your micro classes, competitive model is based on, it's the competitive model drives the supply and demand, curves that you study in your micro classes. And it's based on some assumptions. Competitive market, one assumption, there's a large number of firms. Think about healthcare. Think about Nashville. Think of the number of hospitals. Think of the number of physicians. Think of number of urgent care. Think of the number of PT, the number of positions, a number of physicians and hospitals offering healthcare services just in the Nashville metro area. So you would agree that, at least for that assumption, it kind of falls along the lines competitive model. Second assumption, it's homogeneous goods and services. Okay, I go to see my primary care doc. More than likely, for an office visit, he's going to bill a 99213 is a CPT code, and it's a medium office visit. And if you go to see your primary care doc, he might bill the same thing. And if your neighbor goes to see their primary care doc, he may bill the same thing, he or she. So you're talking about homogeneous goods and services. Now, hospitals in Nashville, whether it's St. Thomas, whether it's Vanderbilt, whether it's Meharry, they may try to differentiate the scope and the quality of their services, but for the most part, it's the goods and services provided across the continuum of healthcare. They're homogeneous. And homogeneous just means, similar, the same. And then the third assumption of the competitive model, we talk about it, it's a large number of buyers and sellers. I mean, heck, you think of the number of people living in Nashville that have either commercial health plan, they may have Medicare or Medicare Advantage, they may have Medicaid, they may have TRICARE, they may have some kind of a independent health plan, they may be private pay. So you've got a lot of individuals within the metropolitan Nashville area on the buyer side of the house. And the same thing on the seller. Again, think of the number of hospitals, the number of physicians, the number of physician extenders that you have providing services. So we're okay, large number of buyers and sellers. And then we come to a couple of assumptions on the competitive model. It gets a little hinky as far as whether the model applies to healthcare, because one of the assumptions of the competitive model is easy entry and exit. Well, if you want to be a physician, I'm not sure it's that easy to enter the market. You've got to go to get your undergraduate degree. You have to go to medical school. You typically get an internship or residency. You may want to specialize in something. And so you've got the AMA, you've got the government, you've got multiple entities out there trying to control the supply of physicians. And it's historically, the government has typical government, they've kind of dabbled in trying to manage the supply of physicians. And because there is such a lag time between when an individual gets into medical school and by the time, again, they go through residency, internship, whatever advanced degrees, from the time they do that, you could be, 6 to 10 years. And so there's such a lag time that the government has trouble forecasting the supply of healthcare providers. So I'm not sure that you can say it's easy entry. Probably easy exit. You can quit whenever you want to, as long as you're willing to assume the financial risk and everything associated with quitting. So you have to really be concerned about that assumption when he talks about the competitive model. And then lastly, complete information about prices. And to me, this is where it really falls off, because healthcare is not consumer centric. If you ask the average individual how much their healthcare costs when they go to see the doctor, most people will regurgitate whatever their copay is. My copay happens to be $10. A lot of individuals copay is $5. A lot of zero copay. A lot of these Medicare Advantage plans, this is zero copay for a lot of the services. So, but that's not the true cost, and that's not the true price of healthcare. The true price of healthcare is whatever. Let's assume that your primary care doc is associated with multiple health plans within the state of Tennessee. He's got a contract with United, Aetna, Cigna, got a contract with Tennessee Blue, so multiple contracts, and the price of healthcare when you go to see the doctor is going to depend on what that contract is negotiated at. So it could be all over the board depending on your physician's ability to negotiate with the health plan. So complete information about prices, to me, that is where the competitive model really falls apart when it comes to healthcare. And then he also gets into the transfer of assets, redistribution of purchasing power, and that's all kind of controlled by public policy. So you've got individuals, maybe an indigent population. You've got some that qualify for Medicaid and Medicare, and you've got employer groups in the Nashville area that are buying health plans and benefit plans from all of your payers. You may even have some in the Nashville area that have decided to go out and just manage healthcare by themselves. They've gone out and they're what you call an ASO, so they are taking the risk for their health care. So it's all over the board as far as prices and as far as the transfer of assets. And as far as when it comes to transfer of assets and redistribution of purchasing power, that almost goes back to Arrow's pushing forward and the establishment of especially Medicare and Medicaid. And then he gets into elasticity, which is responsive to prices. He talks about competitive equilibrium, and that's, that competitive equilibrium is where the supply and demand, they reach equilibrium, and whatever the price and quantity clears the market. Talking about marketability cost and utilities, and really he talks about non-increasing returns, because at least in 1963, it was fairly difficult for physicians to almost establish kind of that marginal increasing of returns. But and then if you stop, and again, if you stop to think about it, what Arrow is looking at is he gets in now to private and social costs and benefits. He talks about risk and uncertainty. Uncertainty turns information into a marketable economy. And it was an issue in 1963 or the late 1950s, early 1960s when he published this article. And it's still an issue in this day and age, because when you go in to see your physician, and it's going to be the understanding and the information available and the ability to use the information available is going to vary across individuals, going to vary across all individuals as they go in to see their physician. They go in to see the physician checks you, the physician comes back and says, well, I think you've got this and that or the other wrong with you, and here's the treatment plan I'm going to recommend. And a lot of people will sit there and say, oh, okay, yep, that works for me. And so there is this asymmetric information that was there in the 50s and 60s, and is still here, because the marketability of information, there's a cost of information, there's a cost associated with it. And some people will argue, well, you can get out on the internet, you go to WebMD or you go to some other internet site, and they say, well, you can get all the information you need. And that is somewhat true, but the cost associated with that, if for nothing else, is just the time and effort that you spend surfing the internet trying to figure out what's wrong with you. And the cost in producing information, Arrow argues, is included in the price of shifting risk. He argues that information improves the probability of buying skilled medical care. And I'll agree with him. It does improve the probability of buying skilled medical care. It's the fact that the information is hard for the average consumer to acquire and to understand and to put it to use. He talks about entrepreneurial markets exist for transferring risk from the buyer to the seller. He's talking now about going down the road of health plans. What kind of health plans are going to be in a position of entrepreneurial position and can move in such a way that for a price, they can shift the risk from the buyer to the seller. And he says, if a market gap exists, non-market social institutions will bridge the gap, with a government agency tending to be the agent that substitutes for market failure. And Arrow's correct. Publishes the article. What's the next thing you see? The politicians in Washington all of a sudden start to read this, and who knows whether they read his article or not. Maybe one of their flunkies read the article, and then they got in the politician's ear. But enough politicians understood what Arrow was talking about, and they were able to move it forward. So government agency steps in. What do you have next? Medicare, Medicaid, CHAMPA/TRICARE. And it's all because of the market failures. And then he kind of launches into the characteristics of the medical care market. Demand is irregular, unpredictable, and risky. Absolutely. How many people go to see their primary care doctor, go to see any kind of a healthcare provider if they're not sick? So, and because of, as Arrow said earlier in the article, the incidence of healthcare is unpredictable. It's uncertain, and the efficacy of the treatment's uncertain. So typically, it is difficult for physicians to forecast demand for their services. There is enough historical information that typically between, say, November to the end of March, there's a higher incidence of flu and colds. Okay. If you look at certain areas of the country from like May to, maybe July or August, there's a higher incidence of allergy. You've got plants blooming, and so maybe it goes back into April or maybe late March, but you've got pollen in the air and you've got issues, respiratory issues. If you're an OBGYN and you have X number of pregnant patients, you can at least forecast to some degree what months you're going to have the most work to do when it comes to delivering babies. So there is some ability to predict demand, but for the most part, demand is unpredictable and irregular. And then Errol makes a statement that talks about satisfaction and potential positive utility only in the event of illness. And remember, from your micro classes, what is utility? It's the benefit or the satisfaction of consuming goods or services. Again, is there a really utility factor baked into healthcare goods and services? I get sick. I don't want to go see the doctor. If I go and he or she cures me, then okay, I guess I've received some utility from that. But if I go to see them and they don't diagnose me correctly and they don't cure me, then there's not much utility there, because when you go to the doctor, there is a cost embedded, an implicit cost embedded to going to see the doctor. And I think Errol understands this. There is the cost of transportation, there's the cost of time off work. And when you're talking about time off work, you're talking about opportunity costs. So there's an opportunity cost associated with you having to leave work to go to the doctor. There's the cost of the visit. There may be the cost of medications. There's just a lot tied up in that office visit to go see your provider. And so utility becomes a factor. And then, there's some discussion about advertising, overt price competition, self-interest of the physician. Treatment is needs-based. Physician, of course, they all think they're experts. Hospital is their motive, it's a profit motive. Hospitals, and it doesn't matter whether they're for-profit or not for profit, it is a profit motive for hospitals. And a lot of it is collectively based. So when you go to see your physician, they are viewed by most consumers as the expert. After all, they went to medical school, so they must be the expert. And there is some self-interest baked into what that physician is, I guess, embedding in your treatment plan for this particular episode of care. Supplies, according to Errol, supply, at least in the late 50s, early 60s, was viewed as a single quality, limited by restricted entry and, opportunity cost. And there was inflexible pricing. And so there was some concern that there was price fixing going on. And so when you're looking at the characteristics of the medical care, at least in that point in time, and to some extent still carries over to now, you have not-for-profit providers, you have for-profit providers. And the perception, at least in the 50s and 60s, is if you went for a not-for-profit provider, then individuals and the consumer of healthcare services or medical care looked at that as they had the perception that if it was not for profit, then their treatment plan was not going to be driven by profits, which somewhat of a misnomer then, and it's somewhat of a misnomer today. There was also the issue with product uncertainty. Physicians have the knowledge, they have the expertise, they have the information, and all of that is greater than what the consumer has. So unless you are intimately involved in the healthcare marketplace of the healthcare arena, it's really difficult as a consumer to know what is really going on when you go into that doctor's office. Supply conditions different from many businesses. Quantity and quality, to some extent, accessibility influenced by, some kind of social market forces. And when you're talking about access, you're looking at, ask yourself, when is the last time, even in this day and age, how many times if you get sick on a Sunday night and you call your physician on Monday morning, how many times can you get in to see that physician sometime during the day on Monday? I can't remember the last time I was able to call a physician's office and get in to see them the same day. It's just sometimes it takes 2 to 3 days. So even when you're ill, accessibility was an issue then, and it's an issue now. Accessibility is driving a lot of dissatisfaction in the healthcare market. And then he gets into the Flexner report, talking about the American Medical Association controlling the supply and trying to input standards both for graduation and admission standards. Flexner report, pretty much was generated, and I think it was Abraham Flexner in 1910 that wrote this report. And he was talking about revamping and centralizing medical institutions. So that was kind of the initial impetus, I guess you could say, into starting to transform, because, the Flexner report argued that there were too many medical schools and the quality of physicians coming out was not what it should be. So started to revamp, medical school and how individuals are trained and how they're going to approach healthcare once they get out in the community. And then, there was price discrimination based on income, and there were some other issues that came out in the Flexner report. So we're gonna stop there for just a minute. I've got couple of more slides to go over when we're talking about Arrow's article, but we're going to stop for a few minutes, let you kind of absorb that, and I will be back in a few minutes and we will get the second segment going. Thank you.